Well, good afternoon, ladies and gentlemen, and a warm welcome from a very, very warm Cape Town. It's a beautiful day out there, and the place is very busy because, as you know, we have the two oceans. The two oceans starts on Saturday morning, so everybody and his wife is there to run the two oceans, and it promises to be a splendid occasion with this beautiful weather. Sports people are abounding. In fact, we've got Chris. Chris, as you know, is a famous kickboxer and cage fighter. And I'd like to thank him for setting everything up over here this afternoon and showing us the tape, which is age-related vaginal microbiome in clinical practice. It follows on Dr. Justina's talk of similar nature. It got so much good feedback that we decided to progress with the vaginal microbe. And so we have Professor Caroline Aebi-Popp, and she's from the University of Bern in Switzerland, the Department of Gynecology, and she's going to be presenting then on behalf of Adcock Ingram, age-related vaginal microbiome in clinical practice. We have over here our co-director, Professor Steve Jeffrey. He is with us this afternoon, and he's going to be assisting with the presentation. So without further waste of time, great thanks to Steve and to Chris, age-related vaginal microbiome in clinical practice. Let it roll, Steve. Hello, Chris. Have you got a sound?
Are you
Hello,
struggling
Chris.
to, yes. Are you struggling to hear the sound on that side?
I don't have any sound. Do you have sound, Steve?
No, there's no sound at all, unfortunately.
Give me 2 seconds, I will fix it now.
So while Chris is fixing the sound, Steve, you know, he's a cage fighting person, as you know, and he doesn't use a helmet. Oh, there we go.
There we go.
Professor Caroline Aebi-Popp. Thank you.
You too. It's a great pleasure to talk about vaginal infections. It's a great topic because I thought it's boring, but it's not. There's loads of research going on. I work as a gynecologist in Linden Hospital, but I also work in research in the University Hospital of Bern in infectious diseases. So today we will look at age-related vaginal microbiome dynamics, and we want to discuss clinical cases of vaginal infections. I also want to highlight some scientific and clinical breakthroughs, and we explore implications for the future for our clinical practices. First of all, this webinar was planned especially for the International Women's Day, and you might ask yourself, why actually do we celebrate next Sunday, the 8th of March, the International Women's Day? The reason is that 1917, Russian women protested on March 8, and this led to the downfall of the Tsar, and women had the right to vote. So you can see that 1977, the United Nations officially then recognized that day as International Women's Day. So please guess now for the first self-governing nation to allow women to vote. And see here, it was New Zealand. It was 1893. And we have to be a bit looking that it took 80 years until Switzerland, where I live, granted women the right to vote, 1971. So coming from the right to vote to gender equality in medicine, are we still there? I think we're not, because clinical trials have always overstudied men and understudied women, and pregnant women are generally excluded from research, and this is not good for our clinical practice and knowledge. And all the drug doses you can find in the leaflets and side effects are often based on male bodies. I think there is still time for a change. So what is the vaginal microbiome? The vaginal microbiome is a community of microorganisms living in the vagina. So researchers say it's like a forest that protects ours, like a good, healthy forest. So the cause for the microbiome, it wants to keep the vaginal environment acidic, and this is protective for bacteria. It wants to prevent overgrowth of pathogens, And actually, it's the driver of our immune system. From childhood on, the microbiome is a teacher for our immune system. And if you look at women, the dominant driver across the lifespan is estrogen. What does estrogen do? It makes the vaginal epithelium thicker, so it's more protective. It affects the glycogen, it affects the pH, and it affects the number of lactobacilli. So if we look at the whole lifespan, you can see on the left side infancy, there's no lactobacilli because they're not there yet, and the pH is more alkaline. And if you look at the reproductive age, then the lactobacilli are the majority, like 90% of all our bacteria. And during menopause, it's a different state again, because lactobacilli, they are less present there. So factors affecting the composition of the vaginal microbiota, there's many things that affect our microbiome. It's stress, it's age. So with the aging, I showed you already, menopause, then also lifestyle and nutrition. Then the gut microbiome, there's a connection between our gut and the vaginal microbiome. Then contraceptives, hormones, antibiotics, and of course probiotics, the same. So there's many things that have an influence on this microbiome. I wanted to bring you 5 cases because I think it's very important that we learn with clinical cases, that we don't look at theory only, but that we have like women come to our practice and we can learn from those cases. So I brought 5 women to this webinar, and they all end on A to make it easier for you to remember. We have Anna, 5-year-old, Lisa, 13, Berta, 22, and Sina is 40 years old, and Ezra is 60 years old and in menopause. So we come to Anna. Anna, she presents with genital and anal itching, and she tells you that this is since 1 week, and it's really predominantly at night. So she scratches her perianal region, and she's when you look at her, it looks like this. This is a picture from her mom, and she has sometimes also vaginal discharge, which is scary, as she finds. So actually, Anna is only 5-year-old. So what you have to think is that you don't do a gynecological exam on your chair, but you can put Anna on a bed, maybe the mom behind her, and the butterfly position, so her legs like this, like on the picture, and you can have a look. But first, of course, you ask her for more symptoms. And if you look at her, you see the hymen, you don't touch the vulva, but you can have a look, because the vulva has very low estrogen, very thin epithelium, so it might hurt her a lot if you put something there, even a swab. And the pH is still alkaline. So if you measure it, it would be 6 to 7. So at this age, there's a very low diversity, and there's very low lactobacilli. So actually, there's no yeast infections because there's no lactobacilli. There's more skin and gut-associated bacteria. So if we do swabs in children or young girls, it's streptococci, E. coli, and more those. So what do you do? Normally, it's a non-specific vulvovaginitis. So that means something is irritating her, maybe a new washing powder, or something like soap, or something that she didn't clean her hands, or something like that. It's irritation, it's red, and there might be some discharge. But as I said, you have to ask for cosmetic things and soaps that might irritate the vulva. But you also can have the group A streptococci that cause a vulvovaginitis. And you can have pinworms. They are quite frequent also in Switzerland, and they cause also vulvar irritation. Candida infections, I always see girls that were diagnosed extern with Candida, and I think that's, if it's a clinical diagnostic, it actually does not exist in such young girls. So what you do, you calm down Anna and you calm down her parents, And normally, if it's irritating, you will say that she could take a bath and some good ointment for the vulva. In the case of Anna, you already might know what it was. Because of this anal itching, especially at night, that gives you a hint to say it's pinworms. It's Enterobius vermicularis. And they come out at night, and they can crawl to the vulva region as well. Normally, it's a clinical, a visible diagnostic. So parents, they say, I've seen it in the stools, or I saw it on her pajamas. So they are 5 to 10 millimeters long, tiny worms, and they are quite frequent in young children. Normally, we don't do the tape test anymore because this is quite annoying. You put a tape on the anus 3 times and to diagnose those worms in the microscope. But you can also start with treatment, and you treat the whole family with mebendazole. The important thing is that you have to do a second treatment after 14 days because of the life cycle of the worms. So you will treat after 14 days the whole family again. And this is a very, very good treatment. You have to wash the bed linen and, of course, the clothes, but it works very well. So when we talk about discharge in young girls, I just want to make the point that if the discharge is smelly or if there's some blood, always think about foreign bodies. Young children between, 4 and even older to 8 years old, they might put anything that's on these pictures here in the vagina. And if you have this foul smelling discharge, please think about it. And they will even tell you that they played around. But if you can see the object, you can use fine forceps. If it's not visible, we use normally warm saline solution to make it visible. But there's vaginoscopy. You can see this on the picture. This, not everybody has that in the practice, but in the children's hospital they have it. And you can sometimes they have to do a sedation in the girl because it's so painful. So we come to the second case. It's 13-year-old Lisa, and Lisa complains about discharge and itching. Very common. So the age, it's early puberty. Of course, it's individually if she's already perimenopausal or if she's still she has low estrogen. It depends on her on Lisa. But normally we don't have to do a gynecological exam, but we can look at her also on the bed, talk to her. And there's, of course, rising estrogen, so the glycogen is also increasing, and that makes bacteria happier if there's more sugar. And the pH is gradually becoming acidic at this age. So actually, the bacteria you find are variable because it's a transition phase between childhood and reproductive age. But there's definitely increasing lactobacilli, but the flora is not yet stable. So what you have to think about when she's 13 is the physiologic leukorrhea. That's normal, white, not smelling discharge, and that's very common before the period comes. You can also think about irritant vulvovaginitis again. Occasional, they have already yeast infections, and BV is less common than in adults, but it's possible to be there. So the counseling would be, in my opinion, very gentle with the explanation that this is not sexually transmitted, because sometimes those young girls are kind of accused that they're already sexually active and they are not. And normally it's symptomatic treatment. In rare cases, we do a swab, but most of the time it's symptomatic, and this irritant vulvovaginitis is treated by giving ointments. So this was what she had, and she did vaginal douching, which you shouldn't do, and this is the best opportunity to tell Lisa not to use much soap and not to do douching, and then you also can calm down and say it's not sexually related, because bacteria can just cause problems there, but you shouldn't destroy your microbiome. So The next patient is 22-year-old Bertha, and Bertha comes and says she has fishy discharge, and it happens mainly after having intercourse with a fixed stable partner. And she was just treated a month ago for bacterial vaginosis. And she's very annoyed that can't be again BV because she took the treatment and she didn't miss a dose of her antibiotics. So 22-year-old, the vaginal environment is now really high estrogen, reproductive phase, thick epithelium, and if you measure the pH, it should be between 3.05 to 4.5. So it's acid, and that is the stable microbiome. So if you look at the lactobacilli, they have funny names: Lactobacillus crispatus, Jensenii, Gasseri, Inners, and actually there's a low bacterial diversity, and this is good. So not high diversity is good in the vagina. It's really many bacteria, but low diversity. 90% have to be lactobacilli, and this is healthy. So Bertha is 22 years old, and she might have again BV, bacterial vaginosis. And just to remember, bacterial vaginosis is an overgrowth of anaerobes. So that's not only Gardnerella, what we learn most of the time. There's other bacteria with funny names: Prevotella, Mobiluncus, Bacteroides, and they are just anaerobes, so they feel very good in a joint infection. So there's also yeast infections, and you see that many times in your practice, and Candida albicans is the most common we see. But also think about sexually transmitted infections in any woman over when she's sexual active, and think about chlamydia, gonorrhea, but also think about trichomonas. And Bertha said she has a good stable partner, and she took the antibiotics, and she can't understand why she should have again BV. So you have to explain that bacterial vaginosis is caused by a disbalance of bacteria, and they support each other. And there's some facts that make BV more likely, for example, after condomless sex, because the acid state of the vagina is then not acid anymore, it's more alkaline, and this makes bacteria easier to grow. And that is actually the dysbiosis she has. So BV recurrence rates, and you might not even know that it's up to 50% within 6 months. So you treat bacterial vaginosis and it comes back. And this is even after correct treatment. So our patients are frustrated because we give them treatment and then they come back. And it's not good to say it's poor compliance. It's actually, it is biology. And I tell you why, but first I will show you how to diagnose BV, because Bertha is there and you have to give her also a new diagnosis. So you might know the Amsel criteria and the Newton score. So the Amsel criteria are more clinical. That's what we see with the discharge. We measure the pH. And of course the whiff test, so the fishy smell of the fluor is very typical. And if you have a microscope in your practice, you see the clue cells on the microscope. Very nice when you start working as a gynecologist and you can identify clue cells. It's a highlight of the day. Later on, you don't have time anymore. But the Newton score is more for labs. So they count the lactobacilli and they count the anaerobes and the mobiluncus. So you can see there's scores between 0 and 10. And between 7 and 10, it's bacterial vaginosis. So just to remember, I mean, we learned that before, but in clinical practice, it's easy to diagnose BV. The really special thing about bacterial vaginosis is the biofilms. So biofilms are like slimy shields, and they protect bacteria from antibiotics, and they protect bacteria from our treatment. So if you give antibiotics, it kills the floating bacteria, the free-floating ones, but the ones hiding in the slimy shield of the biofilm, they stay there. So actually the infection seems to be treated, but after a while it comes back easily because the bacteria are still there, and those biofilms are quite a clever thing for bacteria to celebrate that they are and have an overgrowth there. So what I already told you is that biofilms can remain persistent after antibiotics, and lactobacilli are actually not able to recolonize if the biofilm is still there, and the pH remains elevated. So if you have this in your practice, you can measure it. And just a reminder that she said it happens more if she's sexually active. As she takes the pill, she doesn't use condoms, and the semen pH would be 7 to 8. So this is actually supporting the dysbiosis. The partner transmission of associated bacteria seems to play a role, and this is proven by a new study I will show you. And BV is therefore not a real infection, like a sexually transmitted infection, but it's driven by this happenings. So I show you this study from the New England Journal of Medicine, and it was published last year. It's 164 couples had a completed 12 weeks follow-up. And half of the couples had a treatment of the woman and the man, so a partner treatment, metronidazole orally, and clindamycin antibiotic cream locally. So women had the treatment and men versus only women, what we do normally in clinical practice. And the recurrence rate, you can see it was 35% in the partner treatment group and 63% in the control group. So actually, the study showed an absolute risk difference of 2.5 recurrences per person year. So this is highly significant that partner treatment is superior to only treat women. So this was already new to me because when I was a young doctor, we treated partners, but then we stopped this because we said it's actually not sexually transmitted infection. And now it seems that in recurrent infection, not in one go, but in recurrent BV, there's a superiority of partner treatment. And this is not because Gardnerella are transmitted, it's because all the anaerobes are transmitted from the male partner to the woman, and this makes the recurrence more likely. So what do we do with Berta? We confirm the diagnosis, like I showed you. We can do our Amsel criteria, or we just do a microscopy. And then we have to disrupt that stupid biofilm, for example, with dequalinium chloride. We have to restore lactobacilli, and this is important to inhibit new biofilm formation. We have to do the partner treatment in the case of Berta because she has recurrent BV. And the risk factor modification would mean that she should use condoms, but only until her lactobacilli have restored. And then she can have sex, of course, without condoms. But for that time, I would recommend condoms. And no washing. Actually, if you use antiseptic wash in the genital area, biofilms are more likely to build. That is also something really fascinating, and we can tell that to women who use such antiseptic washings. So we come to Sina. Sina is 40-year-old, and she has a vaginal erythema. She has pain during intercourse, and she has really plenty of vaginal discharge since 2 weeks. And she has some occasional partners over the last 4 months, but she told you that she always used a condom. So she's 40, so their estrogen can be fluctuating. That means the levels are up and down. It's not so stable anymore in some women. And the pH can already increase a little bit. And some women tell you that they have problems in lubrication. So that's depending really on the individual case. But normally the flora is still lactobacillus dominant. So there's an increasing variability of bacteria, and you have to really look at what's happening in your patient. You can't say in general what's going on with 40. Women have recurrent BV at this age more often than very young women, and they have recurrent yeast infections, and they can have both. So never forget mixed or aerobaginitis. It's not only BV and yeast. There can be mixed forms and aerobe bacteria as well. And they can have the early genitourinary syndrome of menopause, GSM. So it's more, actually, it's little estrogen, and it causes dryness, and you know that from your menopause clinics. But always think about sexually transmitted infections. It's one of my favorite topics, of course, but sometimes we forget to take sexual history in those women. So my first point would be always to take a sexual history, and don't ask, do you have a partner? I would rather ask, are you sexually active? Because this is something different, and you want to know if somebody's sexually active. And then think about that bacteria STIs like chlamydia, gonorrhea, they do not cause symptoms in 80%. So sometimes it's just good to do a test. And of course, in some women, you can already offer low dose vaginal estrogens or lubricants. So this is a forgotten guy. I put it a very big picture because when I was young, it was really the best day when we saw those dancing under the microscope. This is really rare because, as I said, it's not easy to see them sometimes, and they are not so frequent anymore. But I found numbers. It's Trichomonas vaginalis. It's an anaerobic protozoan parasite. It's a parasite. And the global prevalence is high. That is why I want to show it to you today. But I found numbers from Switzerland of the Lausanne cohort. There it was 0.5 to 1% prevalence in women. And I think we still have to keep knowing this guy because it can be asymptomatic. And the point I want to make today in this webinar, that trichomonas can also overlap with bacterial vaginosis. And if you have women who can't be treated and they have more recurrences, then think about trichomonas as well. So some facts to this trichomonas, we don't talk a lot about it anymore. The prevalence rates, this was new to me too, is higher in women between 36 and 45 than in younger women. And there's resistance to metronidazole, our favorite antibiotic. And it's a low dose resistance. You can increase your treatment dose to 2 grams for a week. So this is rare in Switzerland maybe, but it's worldwide. It's a really important topic, the antibiotic resistance. And studies are investigating so-called nanocarriers, liposomes, and they can make the antiprotozoal agents like metronidazole more efficient. So this is research, and I promise to talk also about new research. So something that is more, if 8% are positive or if are infected worldwide, this is an important point. And trichomonas is linked to adverse birth outcomes like preterm delivery, infertility, and increased risk of other sexually transmitted infections like HIV and gonorrhea, chlamydia, and so on. So trichomonas is also a sign that the microbiome is not in a normal state and cannot defend the body from other pathogens. So there's a new kid on the block, and this is called Trichomonas vaginalis virus. It's actually a virus that lives in this protozoan, so it's inside. It doesn't affect women directly, but if you treat Trichomonas in women, it can worsen the disease severity first, and then they have something like a post-inflammatory response to your treatment. So you treat Trichomonas, and the symptoms in the women get worse for a short time. But it's interesting that this virus was discovered, and it's called Trichomonas vaginalis virus. So you can't see it. It's too small, but it's there. So we come to our last clinical case, and this is 60-year-old Esra. So she complains about vaginal dryness. She comes and says, Dr. Aebi-Popp, my life is perfect, but down there is Sahara. So this is something I heard last week, exactly that sentence. And she has this, she has an itchy and burning sensation all day long. And everything she used, nothing helped so far. So, of course, now the estrogen is gone and she has no treatment, and the epithelium gets really thin and vulnerable, and it's the pH in Esra is higher. If you measure, it's between 6 and 7, because there's no lactobacilli. Because I told you that lactobacilli love estrogen, and if there's no estrogen, they also don't want to live there. So this is what you see. If you look at the bacteria, you see reduced lactobacilli. You can see some, but not many. And there's more skin bacteria again. Remember, we see some elderly women and they have Streptococci B. Normally we look for that in pregnancy. Or they have Enterococci and bacteria from the skin or from the anus. So Esra can, of course, have the genitourinary syndrome of menopause caused by this estrogen, low estrogen or no estrogen. And as she has a dry skin, dry vagina, and she has also this irritation on the skin. And most of the women also say that they have recurrent urinary tract infections. They never had bladder infections, but suddenly they have it. And they have B-like symptoms, but actually you can't find BV. So they say there's more discharge sometimes also, or they don't feel well. Yeast infections are there, but they're less common. And if I find really heavy yeast infections, I normally look also for diabetes in those women. So first, of course, you know that all. That's easy to do, to give local estrogen and moisturizers and a good lubricant if they are sexually active. This is also crucial. But tell them that this is a treatment for years. It's like brushing your teeth. It's not one course, because most women, they stop after 1 month. They take your prescription and then they stop again. And of course, the symptoms come back. So Esra has also, because I did a swab in Esra and she had candidiasis. So what is different in older women is that they have different candida species sometimes. And we talked about biofilms today, and also yeast infections can make biofilms. So there's candida types, they have azole resistant, like fluconazole, ketoconazole, all that ending on this of those drugs, they are not working anymore. So it's a bit complicated, but I will show you what to do. And as I said, it can be that her immune system is not working well. And if you have repeated yeast infections, you should look for diabetes. And the important thing is that you have to tell her she needs kind of a maintenance therapy. And this is, for example, estrogen. And of course, the barrier of the skin has to be healthy. So in dry skin with little, which is not good in a good state, yeast infections are more frequently found. So that's crucial to explain, because for us it's normal, but for those women they need good explanation how they should proceed. So how to treat those yeast infections? And actually, when I lived in Ireland, we had boric acid suppositories, and they are very good, but they are very difficult to order here, and I think they are more for resistant cases. But we also can use nystatin vaginal cream or suppositories, and this works also well. And as I said, so resistance is very rare. Just think about it. If you have persistence of yeast infections. So this is the case of ESHRA. Now we come to the second part, and this is more what is behind what I told you. Now we had 5 cases between pinworms and yeast infections and BV, but now we want to know what is actually causing those infections and how can we in our clinical practice improve our treatment. First of all, the lactobacilli. I think we learned today that they are very important, and the guy who is called Lactobacillus crispatus is the winner. No, it's the gold standard. It's the best one because actually this lactobacillus is strongly associated with long-term stability in the vagina. It produces lactic acid. There's D and L type and peroxide, and it maintains a very low pH, so between 3.5 and 4. And of course, we learned also today with our case that this can suppress BV-associated anaerobes, like the other one, the Bacteroides, and it disrupts also the biofilms. So important to have 90% of lactobacilli, but of course, during our lifespan, we don't have it. And now comes a question, because I want, yeah.
Yes, thank you very much. So this is the first question for the control of your active presence. So please choose now how many bacteria live in the vagina. So are they 100 million to 1 billion, or 5 to 10 million, or 1 to 2 billion? You have 1 minute to give your answer, and if you are participating from your smartphone, please do not forget to send your answer. We have already 70% giving the answer. You have 10 seconds left. Also, if you are not sure about the right answer, please click. It's very important to get your credits, your training credits. Okay, we have almost everybody, and I close the poll right now. And we have a good mix of the result, so I'll show it to you. We have 48% for answer A, we have 29% for answer B, and we have 23% for answer C. So the most are for answer A. What do you say, Dr. Aebi?
Yeah, that's very nice. Thank you, Framila, because you see that in answer A and answer 3, 1 billion is included. And to be honest, if you look at numbers, you might be confused because it's actually exactly between 1 and 3. But I would say 3 because the more recent research would say 3, but it's per milliliter, you have to imagine, and it's a lot. But I would say both are right because 1 billion is in both, and we just appreciate that you voted. Important is that I already said that the bacteria in the vagina are like a forest, so a healthy, really dense and thriving forest. And the hormones are the conductors who say what to do. And it's a low variety. So 90% of those are lactobacilli in the optimal reproductive age. And this is amazing, isn't it? Because it's so much that's going on there for our immune system. It's not only defending from Gardnerella, it's much more. It's training our immune system as well. So to make it more complicated, but I just show you that because if you are interested in research and if you are reading sometimes papers, you will find the word microbiota community state types. And I just show it to you because we will look at a very interesting research in the next slides. And it uses, for microbiologists, there's 5 state types you've seen here. And just look at the green one, that's the one, number 1. And that's what I showed you, that's the optimal state. And look at number 4, the more red one, that's where the pH is elevated, or the bacteria are feeling very well because it's an alkaline state and they help each other. So actually, this is just to remember for a study I will show you. And to make it easier, the good is the community state type 1, and the bad is community state 4. I don't know why 5 is again a lactobacilli state. I didn't find the explanation, but maybe it was found later. But for you to remember, it's all about balance. So actually, if anaerobes take the power, it's not good. And why did I show you that? Because dysbiosis in the vaginal microbiome is very important, because stress, age, our lifestyle, antibiotics, and other infections can cause this dysbiosis. And as you see here, the immune response is also not like it should be. And inflammation is something we want to actually avoid. All those inflammative, all those kinines, like here, the interleukins, and they just make the microbiome more less defensive. And the pathogens have only a chance if this is like this, the state. And I think it's important if we look, for example, at HPV. Gynecologists have patients and they need loads of explanation. If they have high-risk HPV, they are scared, they want to do something, they say, what can I do to get rid of HPV? But you always have to tell them 80% of all sexual active people in the world have once in their lifetime contact with human papillomaviruses. This is the first thing. But you also can say that also 80% get rid of it. So it's eliminated after about 2 years. But there's little knowledge about factors influencing the persistence. So we could say, stop smoking and lead a healthier life, take care of your immune system. But we don't have good research saying other things. We know that in older age and in immunosuppressed women, HPV is more likely to stay, also in men, of course. So persistence is the problem in causing dysplasia and cancer. You can see here the cancer types. It's not only cervical cancer, it's vulva cancer, vaginal cancer, penile cancer, anal cancer, and head and neck, of course. So if we look at those, remember those community state types, CST, and there's many studies showing that the CST, the type 4, the bacterial vaginosis, is associated with low-grade dysplasia of the cervix. So you see on the picture, the purple is the percentage of women with a community state type 4, so BV and others, so not good. And you can see in healthy women, the percentage is much smaller. And in low-grade intraepithelial lesion and in high-grade lesion and in cervical cancer, there seems to be dysbiosis. So I think this is really interesting research. I just show one publication, but there's more, and they show the same results. So maybe in the future, and this is my summary of the microbiome diagnostics value for the future, maybe in the future we can be more, we can offer more individual care, and we can have a better early detection of women who are more likely to have HPV for longer and other bacteria. But this is not only about HPV. You can see on this picture, it can help to avoid, for example, preterm deliveries. If we know that the microbiome should be healthy throughout the pregnancy, it could help in fertility clinics to have a healthy microbiome. It could also help in menopause, but also in polycystic ovarian syndrome patients, but also in oncology, like I showed you with the example of HPV. The microbiome seems very important because it's the trainer again and the supporter of our immune system, and also in other infections. So I find this overview quite interesting where future research could go, because so far the microbiome was more for researchers, but it could have an influence and it could be valuable research to have better tools and targeted care for our patients. So we come to the take-home messages, and then we have enough time for your questions. First of all, I hope I could show you that vaginal infections are lifespan and estrogen dependent, that you always have to think about the age first and what you might find and what you cannot find at this age. The microbiome is also, it's science going on, and it's reshaping our disease concepts. For example, for me, bacterial vaginosis, since I'm working, the concept of treatment, they changed. Biofilms have really an important part in recurrent infections, and we have to learn more how to treat those. And in terms of worldwide antibiotic resistance, we also need non-antibiotic treatments for those infections to avoid giving more antibiotics to our patients. So this is also important. The partner treatment in bacterial vaginosis seems superior. I showed you the publication. And if we look at vaginal microbiota, this can lead to more individualized treatment concepts. I showed you the example of pregnancy and preterm delivery. So maybe for the future, the microbiome diagnostics will help us to support our patients better. So I thank everybody who kept listening during this webinar, and I really want to answer all your questions, and maybe we have a nice discussion. Thank you for listening.
Yes, thank you very much for this very important insights. We already have some questions to start. We have, do you recommend to treat the partner every time in your clinical practice for BV cases?
No, I'm sorry that I didn't say that clearly. I do it in recurrent BV cases, and so not in everybody, no. And you also have to think it has to be a stable partner if you treat it, of course. So ask for sexual history, and if BV is a one-time infection, I don't treat the partner yet.
Okay, thank you very much. Also a question for treating others. Do you always have to treat the whole family with, this was in the beginning, with the Mebendazole, sorry.
Mebendazole. Yeah, I mean, it's recommended to treat the household. So if you live close, and it depends on the age of children, you can do other measures. You can treat your child, and if you think you have no symptoms at all, normally it's really recommended, and it's so harmless, that medication. It doesn't cause any side effects, and in some countries, some doctors in Latin America, they take it routinely every 6 months, but not here, of course. But you don't have to be afraid to take it, but you have to take other measures like shorten the fingernails of your children and wash, of course, the beds minimum 60 degrees. And you have to take care of that too, that you don't have a reinfection. But normally it's really good to treat the whole family.
Perfect, thank you. And do you recommend the use of lactobacillus to modulate the microbiome in HPV cases?
Yeah, that's a very interesting question, and that's going here in my head, and I can't. There's not much evidence, and I want to say this is really a personal opinion. I was fascinated by reading those studies. I showed you one. I think it's something to think about, because first of all, we have nothing we can do at the moment. As I said, stop smoking is very little. If somebody does not smoke, there's not much to do. And I'm convinced that the microbiome has an influence on persistence of HPV. I mean, studies have shown that. If we can get rid of it, there's not much evidence. What I have shown you is that the persistence is more frequent. But the other hypothesis that you can really eliminate HPV by lactobacilli treatment, this is not proven yet, but maybe in the future, and I think this is an interesting question. If the lactobacilli are not so expensive, I would say in women you could be very honest with your patients and say that there's not much evidence, but they can try. Yeah.
Perfect. Yeah. In patients with cervical dysplasia, how would the treatment with lactobacilla look like over 6 months?
There's no. This study showed that the state, the community state was there when they had dysplasia, but there's no data to show that if you restore lactobacilli, the high-grade lesion would be better after 6 months or 3 months. There's nothing. Just to be sure that I don't confuse people, but there's also no guidelines yet. I think we're in a early, everybody knows from if you work as a gynecologist that there are products under research that you can give different microbiome supporting products. And there were studies, but there were single studies, and there's not so much evidence that the guidelines changed. So in the colposcopy clinic, we don't routinely give lactobacillus products. It's more, if the cells are already different, you can't maybe do anything in that stage. But what I think is if the virus is there and it's not yet in the cells and it does not yet cause dysplasia, that would be the time to maybe support lactobacilli. Not if they already inside of the cells changing those. That's a personal opinion, but I think we're not yet there. Mm-hmm. We need more data.
Okay, there is another question. How to increase the Lactobacillus crispatus? Are the oral probiotics helping, and is there data about it?
Yeah, I found some data that the gut and the gut-vagina axis does exist. We prefer to give it in the vagina locally, but as I told you that also nutrition and lifestyle has a factor on the vaginal microbiome. Also, if you take those orally, the microbiome improves. So there seems to be a body network of the microbiome. It's not only that they are disconnected and each microbiome works for itself. They are connected. And yeah, if it works, there's some studies that oral taken. I doubted that a long time, but I found some studies. But normally I prefer locally. It's more, I don't know, it's more in my clinical practice that we use those lactobacilli locally. But of course, if there's this network and the connection, they should work, yes.
Okay. In a menopausal woman, it is sufficient to use local estrogen, or do we also need lactobacilla?
I think it's to use ointments and lactobacilli are not always needed because the estrogen will make lactobacilli love estrogen. As I showed you, the proportion is sometimes the same. The more estrogen, the more lactobacilli. So you can't give lactobacilli if they don't have estrogen. You can give them to a menopausal woman without estrogen and they will disappear in no time. But normally estrogen is enough. But what you should do is, if they are sexually active, to avoid to give lubricants and good ones, to avoid little crackles in the skin, because this makes, for example, yeast infections more likely to occur. That you really don't forget to give lubricants as well for sexual activities.
Okay, we have many questions. Hopefully you have power enough to reply. So there is a question. Lactobacillus level are low in older women. In this case, do you recommend using more products containing lactobacillus, such as Cynoflorel gel?
understand, because so if they are low, if I recommend.
I think the question is it enough to use just gynophilol gel, for example, or do they need more, for example, as a local treatment with gynoflor? Or
I mean, I found many products. Of course, this is this viewer mentioned one product. Maybe the question was use it on the vulva or in the vagina. So two different ideas. Some, of course, the microbiome or the lactobacilli are more vaginal, but also on the introitus. So I think it's an individual answer. I can't say. Maybe you start with one product, you see how it works, and there's few products. Maybe you have good experiences, and you can add another one. But normally, I wouldn't never give 2 or 3 at the same time. This confuses. You never know what worked. And in menopausal women, as I said, I believe it's really important to have estrogen twice a week, to have a good lubricant and ointment for just for the dry skin. And lactobacilli, it depends really. It depends. Early menopause, you wouldn't give lactobacilli to a 78-year-old woman who has no problems. Why? I mean, it's all a question about, as I showed you on the picture, about balance to the right time. But in the transition phase, I'm sure it'll have an impact. Or in women having more infections and having more problems, that lactobacilli can help to restore the environment. But that's all Aebi-Popp opinion. Don't put me in prison for wrong. That's my clinical practice, and I don't know everything. I'm just fascinated by that topic, and I read a lot. But I think that sometimes we don't have such clear guidelines, because maybe that research is growing, and you should have more time to read all the new papers. We all don't have that time, but we try to keep up with what researchers find, that we adapt our clinical practice to that.
So they really, really want your opinion, because we have a question here directly to you. It's written in German. So which product would you recommend to improve the microbiome in case of infertility?
Well, ladies and gentlemen, it's a very, very interesting topic, and I'd like to thank the presenters, Professor Caroline Aebi-Popp, for it. We have a couple of questions. Steve, would you like to read out some of the questions?
Yeah, Peter, I thought it was very interesting. I mean, I think in the end of the day, vaginal microbiome is better off when it's less diverse than more diverse, which is quite interesting.
Correct.
Obviously being very lactobacillus based. And there's actually only one question I have here, Greg Klopp. I couldn't click on the square, so this is obviously because it wasn't an interactive webinar, it was a recording, so sorry about that, Greg. But Jessica Elston wants to know, is there a role for probiotics in women with recurrent infections? I believe, depending what sort of recurrent infection you're talking about, in my opinion, for recurrent bladder infections, we do use it. Just think we're still stuck in terms of our product available. The one probiotic that does have a fair amount of lactobacillus rhamnosus in it is Ruterina Fem, which I know a lot of people do use. But, I think it very much comes down to restoring the microenvironment of the vagina. I think you restore the lactobacillus best by giving your patient a very good amount, especially postmenopausal patient, the estrogen therapy. So I think you're restoring your microbiome best by restoring that. What are your thoughts on that, Pete, on that question?
Yeah, she did have a funny accent a bit at the end when she said gynoflor. I don't know if anybody picked that up, but yeah, that has, yes, it is available locally by our sponsor Adcock, and that is estrogen plus lactobacillus for 6 days. So I should think that probably fulfills the criterion that you mentioned, and it would help Jessica's problem. So gynoflor has estrogen plus lactobacillus, but the basis for everything, as she said, is the estrogen. Everything is estrogen dependent. So that's where you'd begin, Steve.
Pete, wouldn't you give the Gynaflor for longer though? I mean, it's I don't think
you could repeat it, but
yeah.
that's just the starter dose. But certainly, as the presenter, Professor Caroline Aebi-Popp, said, it's a bit like cleaning your teeth. If you're going to take vaginal estrogen, if you're menopausal, you can't just take it. You've got to take it for several months, if not years. Yeah.
Yeah. No, it's a very interesting topic. I think we've got a long way to go in terms of this topic that Pete and I think we are onto something very important, but just microbiome therapies are still so way off, and I think it's and I mean I know our friend Tina Wajno was quite set on this concept of adding raw biotics, that whole idea of putting the tampon into the bottle of raw biotics and recolonizing it that way. But I don't know. I mean, that doesn't really have any lactobacillus in it. So I don't know what your thoughts on that are, Pete. But
she did mention lactobacillus in terms of yogurts. But
yeah.
Steve, I think until we get Lactobacillus crispus available clinically, I think unfortunately we either have to do the Gynaflor or go the yogurt route until the other becomes available.
Yeah, no, you're right, Pete. Interesting topic, and I think we'll hear a lot more about this in the future, Pete. It's I think we're still in the infantile stage of this, but great that we've got a product like the Gynaflor. It was a great advance, and it might be quite nice to get a little bit further discussion around that specific product going forward.
I agree, Steve. Steve, would you like to thank our presenter, Professor Caroline, in
absence? Absolutely. I think it was great, and it's nice to hear that people are so passionate about this very specific topic. For a lot of people, this is not something they're really that interested in. So to have someone who's so passionate about it, I think is amazing. So absence, we could like to just express our thanks to her for allowing us to use a recording,
and Adcock for allowing us to use
absolutely it. To Adcock for bringing us into that specific webinar, which was obviously held in a different time and place. But we do appreciate that very much, and we obviously appreciate their support for the webinar. And again, to Chris and also to you, Pete, thanks so much. I'm sure you're going to go and jump into your pool now, Pete. It's so hot now in Cape Town. But,
Okay, well, thanks everybody for being present. Safe home.
Thank you very much.
And see you all same time, same place next week. And the very, very best for you, Steve, and those that will be running, and for you, Chris, those who are running the Two Oceans. Good luck and take care. Break a leg.
Thank you. Yeah, bye-bye.
Thanks. Bye-bye.